My name is Athul Sathian, and my presentation examines the case of Nicholas. Starting with pathophysiology, prostate cancer is a malignant disease of the prostate gland, and it usually originates from abnormal changes in glandular prostate cells. Most prostate cancer cases are adenocarcinomas, which means that they arise from malignant transformation of glandular cells in the prostate. These abnormal cells eventually multiply and they form a tumor within the prostate, and their development may occur through spreading outside the prostate or by affecting surrounding lymphatic tissue. Prostate cancer can vary in severity as some cases remains localized, while others progress aggressively to metastasis and treatment resistance. One of the most common cancer in men is prostate cancer, and contributing factors include genetic, dietary, environmental, and hormonal influence. However, in Nicholas' case, it is his age and family history. His lymph nodes were also surgically removed to check for regional lymph node involvement, although his CT scan showed no signs of metastasis. Moving on, his diagnosis is supported by several findings from his medical record. Nicholas' prostate-specific antigen or PSA was elevated at 7.5, and a digital rectal examination discovered a hard lump. His biopsy results revealed that he had prostate cancer with a Gleason score of 7 PSA level. Biopsy, Gleason score, and clinical stage are important factors used to classify prostate cancer risk and guide treatment planning. Therefore, Nicholas Gleason score of 7 highlights clinically significant prostate cancer, which requires surgical management. Nicholas also had additional non-modifiable risk factors. His age of 69 is relevant because prostate cancer risk is higher in older men. Other risk factors include his family history of cancer, specifically his brother was diagnosed with prostate cancer and his mother died because of breast cancer. Current evidence identifies increasing age, genetic factors, and family history as important prostate cancer risk factors, while dietary, environmental, and hormonal influence may also contribute to risk. But information regarding genetic testing is not presented in the case study. Moving on, one important pharmacological intervention for Nicholas would be to administer prescribed analgesic and assess the effectiveness of the medication using a pain assessment tool before and after administering the medication. Because Nicholas had a retropubic radical prostatectomy with an 8 centimeter incision in his abdomen and an indwelling urinary catheter, he might experience uncontrolled pain that can reduce his movement and affect deep breathing and recovery. The RN needs to assess his pain both during activity and at rest. To control acute, moderate to severe pain, administer routine analgesics such as paracetamol if prescribed, and administer PRN short-acting opioid analgesics if needed. Additionally, the RN needs to monitor sedation, respiratory rate, nausea, vomiting, and constipation due to the side effects associated with opioids. Among the non-pharmacological interventions, focus should be on supporting Nicholas with positioning, splinting of the incisions, and gradual mobilization. Using a pillow to support the retropubic area while repositioning, cuffing, and mobilization can help reduce stress on the operated area and decrease the pain felt during movement. Also, making sure that the urinary catheter is properly secured and preventing any traction can minimize discomfort. These interventions are relevant because they can be implemented alongside pharmacological pain relief interventions to maximize patient functional capabilities and well-being. One of the priority nursing interventions that needs to be done on Nicholas is to regularly assess and monitor his 8 centimeter retropubic incision for any post-operative complications. Perform wound assessment on the incision site and the area around it to look for any signs of bleeding, redness, swelling, warmth, odor, open wound, and drainage or jet discharge. Any findings from these assessments needs to be noted in the EMR, and it must be reported if abnormal changes happen because he just had a major surgery done. Other priority nursing interventions would be to employ aseptic non-touch technique during wound care and any interaction that involves the surgical area. The RN must perform hand hygiene, arrange a clean environment, wear appropriate PPE, protect key parts and avoid contamination of the dressing equipment or the wound. This is important in Nicola's case because his surgical incision is a critical site that might enable pathogens to enter his body, leading to an infection. Maintaining aseptic non-touch technique decreases the chance of contamination, prevents a healthcare-associated infection, and promotes safe wound healing after the procedure. Now, moving on to discharge planning. Before his discharge, Nicholas needs to be educated about his indwelling urinary catheter and the surgery that he just went through. The RN must teach him on how to keep the catheter in place, prevent pulling or kinking of the tubing, keeping the drainage back below the level of his bladder, report any fever, foul smelling, or hazy urine, worsening pain, decreased urinary output, no drainage into the bag, or severe hematuria. Additionally, he needs to be educated on to notice signs of delayed healing and infection, such as swelling, discharge, warmth, redness, odor, or wound separation. Nicholas also needs to be educated about his physical activity limitations, pelvic floor exercise, continence, pain medication safety, and follow-up treatment. The RN should encourage Nicholas to exercise bladder control techniques, wear continence pads if needed. Additionally, he should be encouraged to seek assistance if leakage continues or it gets worse because of urinary symptoms following the prostatectomy. This can negatively impact his everyday life and psychological wellness. Nicola should also refrain from heavy lifting and resume cycling and other physically demanding activities only when the surgeon tells him that he is clear to do so. Doing a follow-up visit after a radical prostatectomy is crucial for wound evaluation, catheter removal, and pathology results and continuing the PSA monitoring, which is prostate-specific antigen monitoring. Finally, multidisciplinary support for Nicola should include a urologist for cancer and surgical follow-up, a physiotherapist and continence nurse for pelvic floor rehabilitation, a general practitioner for ongoing monitoring, and a registered nurse or a chemist for analgesic medication education and opioid wearing if required. He may also receive support with adjustments, anxiety, body image, sexual function, and continence issues following prostate cancer surgery from a nurse counselor or psychologist. That's all. Thank you.